Hey everybody, welcome back to The Pathway. It's Taylor Henrik here, and I'm here with my colleague Sarang Patel.
Hey.
And today we're going to be talking about a variety of topics. We're excited for you to come along with us today, and we're going to get right into it. I think the first thing I'd like to do is just allow anybody listening to the pod today. Obviously, they know who Sarang and I are, but I'd love for them to get the opportunity to get to know our guest today, Michael Hunter.
The Michael Hunter.
The Michael Hunter.
Michael, why don't you give us a little bit of a 411 about who you are, where you work, who you lead?
I'm Michael Hunter, and publicly I am the president of Team Wellness Center, which is one of the largest community mental health providers in the state of Michigan. And I have been with the team for 20 years as of June 5th-ish of this year.
Oh, wow. Congrats.
How about that?
You a vet.
Just past the anniversary. That's huge. We got to celebrate that.
Tenured
Yes.
times 2. Is there something more than tenured? No, it's tenured.
No. Tenured is a term.
Yeah, but what about after that?
It's not 10 years, it's tenured.
Tenured. Tenured.
He's at 2 decades.
Yeah, so what is it? So 10 years, but 10 years, like after 9 years, you get tenured, right?
For like if you work at a university
Yeah.
or something.
See?
Oh, okay.
Yeah.
I was mistaken.
But then I was thinking, so now that he's at 20 years, what is that called?
I thought tenured was a term that wasn't
Dos
indicative of
Equis.
any amount of time.
Dos Equis.
Dos Equis.
You are the Dos Equis.
Well, we got to celebrate. I think we're overdue for a celebration
It's not
between us
Dos
three.
Equis. I think so,
Congratulations
too.
on 20 years.
Thank you.
Wow.
Thank you.
Keep going.
It's been a very interesting ride, as you can imagine, because
Sounds easy.
if you don't know what community health is, first of all, then community mental health is a whole nother industry. But it's been wonderful. I think the biggest takeaway I have is appreciating and looking over my shoulder of when I've been in need of mental health services and did not know it because I didn't know the vocabulary or the terms. And I think a lot of people are there today. I think that the other thing that I've probably been enriched by the most is working with people in the industry from other agencies. And that has really, really given me a new perspective about this industry and the people that are in there and why they're there. And from the prescribers, the social workers, the therapists, the traditionalists, the people that are outside the box, and the bureaucracy. Oh boy. Yeah, so it's been a really, really interesting time, and I'm really blessed to be here still.
I have a million questions.
Okay.
Can you first tell us, so you mentioned that you're the president of Team Wellness Center.
Yes.
Where'd you start within that organization?
I started as the director of human resources.
Wow. Like right off the bat?
Right off the bat.
Oh my gosh. Okay. All right.
So they needed a human resource director, and previously I had worked in a industry that designed computers and software for collecting bad checks. So I worked in an industry that was behind the scenes doing computer programming, et cetera. But I was the director of operations, so I basically was like a family practitioner and did it all. So
Got it.
my MBA concentrates on human resource management. So I applied for that job and they hired me. When I was hired, there were no computers in the company. Well, there were 2. There was one in accounting and one in payroll.
And we're talking, this is 2005.
2005.
This isn't the Stone
21st
Age.
century, right?
Yeah, what the heck?
Seriously?
Seriously. And so I was really taken aback, like how is this even possible in the 21st century? But it was, and they were a 200 employee company at the time. Today we're 480, 500 employees.
Wow.
And
That's
so
big.
it was really interesting. And we had
is
locations all around the state of Michigan in group homes,
Okay.
but no computers.
So everything was paper charting, safe to
Everything
say.
was paper charting.
How'd they e-prescribe? Wait, they
Stone
didn't
and
e-prescribe.
chisel.
They didn't
They wrote
e-prescribe.
prescriptions.
E-prescribing wasn't out then.
Oh, gotcha.
It
It was
came
just
later.
paper.
You're still carrier pigeons.
Yeah.
Carrier pigeons.
That's what they were doing. That's what they're
Carrier
doing.
pigeons.
Zoloft.
There you go.
Right.
Send it. Take to CVS, please.
And when the pigeon didn't come back, you knew what happened.
No meds.
But it was pretty exciting, man. I was thoroughly intrigued that the industry had so much bureaucracy because my first week there, they said you're going to be audited. And I'm like, audited? I'm human resources. I know what an audit is. They're like, no, in this industry, the audits are all bureaucratic audits. They're looking at the human resource files. They're looking at the medical charts. They're looking at your business records, the whole thing. Mm-hmm. And I'm like, okay, no problem. But in order to get this accomplished, they said you have 1 week from today, from your day of hire, for your first audit.
No orientation, no onboarding, nothing.
Nothing.
And you had to clean up everything that was existing there?
Yes.
Wow.
And so I'm like, hey, no problem. Because, you're the new kid on the block. You got to prove yourself. Open the drawer of files, and there was an applause of Post-it notes. And I'm like, we're not going to pass this audit, right? We've never failed an audit. Well, welcome to America, because we're going to fail this one.
Wow. Talk about pressure out the gates.
Yeah. But we never failed another one.
Okay.
Hey,
Because
okay.
right after that one, I said to the owners, we need software. They were like, for what? I'm like, oh, let me take a step back. We need computers.
We need computers. We need at least DOS. At least DOS here. Preferably not, but we'll work with it if we have to.
Microsoft Office 95 was out at that point.
Yeah.
So we strategized and said, you're right, and really it was fun to be a part of that evolution for us as a company. And so then I was like, okay, to manage 200 lives, I need a computer and I need software. And it can't be software you're going to buy off the shelf at Staples or Office Depot. So you need customization. Yeah. And they were like, okay, let's parade in our potential designers that, design software. The lowest bid was cost prohibitive. It was outrageous. And they were like, well, we can't do that.
What was this?
And they were like, but we hired you to be our director, so it's on you. And so I wrote the software, the human resource management software. And they still use it to this day.
Wow.
And we've gotten international and national acclaim from it, from our accrediting body. And it just revolutionized not just our company, but the industry. And what the industry recognized, I think at that time, is that, man, even a community mental health provider can use electronic record keeping. Mm-hmm. And because at the time it was unheard of, literally.
So during that time, we're talking circa 2005.
Yeah.
Other community mental healths in the area that you were aware of were also mostly paper-based, not digital?
100% were 100% paper.
That was market standard.
Correct.
Interesting. So you actually did shepherd in a change for the governing body, right? Or for CMHs, that it was okay to move to digital?
Correct.
Wow.
I think that made it really, really palatable because we put it on display. We talked to all our payers. We talked to the people at the state. Every chance we got, we put it on display. And at its infancy, it was very, very generic. It was very basic. Today it's more complex, but back then it was very basic. But it did the job. So that was in June of 2005. By November of 2005, we recognized we had the same issue, or I recognized it, but on the paper charting scale. So we were getting an audit by our payer, and they said, we're bringing in some Medicare experts to do this audit. And we were like, okay, but it's all paper. When the audit was over, they were like, this is insane.
You failed.
This is too much paper.
Yeah.
They said, we got good news and bad news. And we were like, what is it? And they said, well, the good news is we don't anticipate or suspect any improprieties. But the bad news is this just screams of inefficiency. Mm-hmm. How do you do this? How do you do this in the 21st century, still with pen and paper? And it was just, missing documents here, missing signatures, just you name it. It was just bad. Mm-hmm. But when they picked up the phone and called the patient and said, hey, did you get these services? Were you here on this day, this day? Yeah, I go there all the time. Yeah. And then no one ever disputed that they were actually getting the care. But a paper, that flies away out of a paper chart, that it's just no. That's why I don't use Post-it notes today, because it
Correct.
goes away, right?
Yeah.
So they told us we have to have an electronic medical record. This is right before Thanksgiving. And they want to see it by December 5th of that year. And we were like, okay, so we'll come back. And we looked around. We paraded through the programmers again. Cost prohibitive, astronomical cost estimates. And we were like, we can't do it. So we said, what are we going to do? And they said, well, we have to just go and throw ourselves on the sword and say we can't do it. I'm like, that's going to put us out of business. We don't. What else do we have? We're going to ask them to pay for it? Well, they're not going to pay for it.
Right.
And I said, I'm just going to have to write it. You think you can do that? I'm like, I don't know.
Figure it out.
Yeah.
So I went on this quest to write the software, and then I got a blessing because they said, hey, we're too close to the holidays. We're not going to meet on the 5th. We'll meet in January. I'm like, great. So by the time January rolled around, I had a pretty good prototype done. Went and presented it to them. They fell in love with it. Oh my God, I can't believe you guys pulled this off. And now, when will it be live? So now, you know what live means? All of this paper has to become electronic.
Right. Right.
And so we said we would start immediately. Give me a month. So March 1st, we'll go live. So from December 5th to March 1st, live. And we did it.
It's pretty fast, actually.
Wow.
Yeah.
It's really fast.
And for our listeners, they should recognize this is prior to ChatGPT writing code for
Oh,
you.
yeah.
This is prior to you being able to plug something in and spitting it out in seconds. So you wrote code. You wrote an EMR on top of revolutionizing an entire HR program for a 200 plus employee company, all over the span of your first 6 months at the company.
Correct.
Damn.
Wow. Yeah. I mean, talk about hitting some landmarks and hitting milestones as a new employee.
Yes.
So you instantly become a very valued member of this team.
I think so.
Yeah.
I think so. And then so we used that software until 2016.
Okay.
By
wow.
the
Yeah.
time 2016 rolls around, the federal government started incentivizing physicians to implement their own EMRs just across the board. So that made it spill into our arena as community mental health providers and clinics, and because we all employ and work with prescribers. But you would be amazed at the number of prescribers that had a lot of pushback just because they were just old school,
Right.
prescribers.
Yeah, for sure.
Yep.
And so as I'm learning more and trying to stay on top of the technology and up with what the requirements are, my time just became the commodity. It was just no way I could do it all. So I was like, well, we got to make a decision as a company. Am I going to be the chief information officer and continue this, or are we going to switch software vendors? And so at the time, the county was using a local vendor, and a lot of providers started to buy into that vendor. And so we switched to them, as opposed to hiring an entourage of programmers and a whole IT department. But the HR software was still used, yeah.
That's amazing. One of the things that I wanted to ask off the bat, you talked about differentiating between community health centers and community mental health centers.
Yes.
For those individuals who may not know either, can you kind of give us just a little bit of background of what these types of healthcare facilities do and who they serve?
Yeah, so when you think community, just think of any neighborhood in our country, but it typically tailors itself to the indigent population and people who are not financially well off. A lot of time, people who are underinsured, definitely uninsured. And so these clinics historically in America were born out of nunneries, if you will. So the Catholic Church and the Jesuits did a lot of work with nuns taking care of the sick and the indigent. And they began these clinics, and those clinics turned into hospitals.
I did not know that.
Yeah, some of the ones that you know are more renowned are like the Mayo Clinic,
Yeah.
Cleveland Clinic, same kind of starts.
Is that like DePore's and some of those? Like even, obviously, both of us being U of D grads, the Jesuit
Yes.
opportunities and the mission that they carry?
Correct.
Okay.
Correct. The Jesuits are really big on educating and in medicine and stuff like that. So those clinics were designed to take care of the people who didn't have money to afford. And so now when you think of community health, that's where that lands. And a lot of people who are indigent know that. Unfortunately, it's been generational for a lot of them.
Mm-hmm.
But now you add this mental health component to it. Historically, at that same time almost that we were using these community clinics, we were also building asylums. And the asylums were being built initially for the rich and famous who had somebody in their family that they didn't want to be around, but they wanted them to be taken care of. So you had prescribers, doctors saying, okay, I'm going to create an asylum. I'm going to take good care of your people. I know I'm going to try all these things on them and they're going to be well because of it or be better because of it. And what it turned into was we can get rid of the whispering. We can get rid of our stigmas and our embarrassment if we just send Katie over to the asylum.
Mm-hmm. Yeah.
As long as we can afford it.
Mm-hmm.
And then when the indigent started having the same problem, it was different motivation though. The indigent didn't say, hey, I want to get rid of so-and-so. The indigent, typically at first, the caregiver passed away. So you have this child with special needs and eventually you get older and you pass away and there's nobody to care for the child. So where did they put him?
In an
So,
asylum.
well, let's put him in an asylum. So the asylum started with some charity at first, and yeah, come on in, but then it just began to balloon and the popcorn, and then the rich and famous were like, I don't want to be in that same asylum.
We're not sending people there.
Yeah,
We're sending them to
we're gonna have
rehab.
the exclusive ones for rehab versus the
wellness
now.
spas.
Yeah.
So community mental health
Yeah.
at first was an asylum. It was inpatient. It was locked. You couldn't. It wasn't by your choice. That's where it was.
Notoriously, one of the well-known ones was in my hometown, the state hospital up in Traverse City. When I was growing up, my mom was a dietitian, and she used to round there. It was open during our lifetime, obviously.
Yeah.
And she remembered it was a tough environment.
Have you been up there lately?
Yeah. Now,
Campus is still there.
yes, it is. Now it's completely renovated. It's residences and it's residential and commercial. It's now called the grounds or the common grounds or high grounds. A couple restaurants there.
Yeah.
It's beautiful.
Yeah, it looks really serene. Looks nice.
Wasn't before,
Right.
but it's been renovated appropriately. But it's just interesting you bring that up. Please continue. Sorry for the segue.
I mean, they're everywhere, and Michigan had its share, of course. Some more notorious ones was the Pontiac Asylum.
Eloise or no?
Eloise is in Inkster, Dearborn.
It's one in Northville, is it?
Eloise is the one by.
Northville was another notorious Michigan, but there was a huge one at the corner of Elizabeth Lake and Telegraph.
Okay.
Now it's a bunch of houses or condominiums right now.
Oh, I know what you're talking about.
Yeah. I don't know what the name of it was.
It's not Arkham.
It's that big brown building, right?
Batman.
It was a series of buildings.
Didn't someone just buy that place out?
No, this is when Governor, who was Michigan's governor then, Engler, when they released, quote unquote, all of the people out of the mental institutions, state hospitals.
It was Governor Engler, yeah.
So it was a location there, right at the corner of Pontiac and Elizabeth Lake. We'll have to look it up later.
Yeah.
But it was a series of asylums there, and they tore them down and built houses on top of them.
Wow.
Wow.
Yeah.
I never knew that was the part of the origin story for the community mental health clinics or
I had
centers.
no idea.
Yeah, and so what began to happen is President Kennedy, a lot of people don't know this too, I think one of his last bills that he signed into law was the Mental Health Act, to have us really as a country take care of people with a mental illness, formally, and to cover them with protections and stuff like that, which is what drove the closing of the asylums over time, because initially everybody celebrated, okay, right, 65, but we didn't close these asylums until what, 97, 95, something like that.
During our lifetime. Yeah.
Yeah, so you still see that bureaucracy piece, right? How long it takes to get it done, to get it enacted.
Yeah.
But anyway, what began to happen around the country is the people in the asylum started being exploited, taken advantage of. And for example, I'm going to give you a very basic one, but you can just imagine. The patient is in there. She's 25 years old, and she's mute. She can't talk. She has some other cognitive disabilities. and now she's pregnant. So how is that happening?
Right.
A lot of premature deaths, unexplained deaths, unexplained injuries, using bully tactics to coerce them into cooperating.
Chemical restraining.
Yeah. Electrolysis.
ECT.
Yeah.
Yeah.
So that's why they shut the asylums down, because of that stuff.
Correct. They were super overcrowded.
But they're all government regulated, right? Or state regulated?
They, at the time, no. Eventually, yes.
I think there was little oversight. That was part of the problem.
Yeah, it was very little oversight. But even when you got to the state level, it was the same problems. So whether it was a private institution or a public, it was impossible, apparently.
Now, what happened when those closed? Because I understand that was quite a difficult transition time as well. When the asylums closed, what happened to those individuals?
Right,
yes, exactly. So when you think about, now let's broaden into community mental health.
I should have brought a notebook.
So now we're into community mental health. We've talked about it from its evolution a little bit. So now you imagine that when the asylums existed, who was the prescriber? Who was the doctor? Well, it was an MD, which was always a prominent position, right? So this MD typically had a private practice in an affluent area of the region, and would be kind enough to donate, his time a day a week. Whether it was in the evening or whatever, over the phone, and they would pay him handsomely, and typically it was him back then, pay him handsomely, or her, and then he would do what he needed to do. But basically the people on the floor, typically a director of nursing, was in charge, and the orderlies were the enforcers. And then when you said, okay, we're releasing them, where are they going to go? Well, you're my doctor. I'm coming to you. In West Bloomfield? No, you're not.
Yeah.
It's a different population.
Different population. So,
economically, socioeconomically, it's a very different.
Correct.
Different look.
So where are they going to go? So what we did as an industry and as a country is said, okay, if the doctor's role is not really the same affect as it is, or the fidelity that you have in the physical health realm, where your doctor is very much engaged in your care, what does the doctor do? Well, they do medication management. They're the ones who are writing the orders to give you the medication. They're the ones who are backing the PRNs and shock treatments and that kind of thing. They don't want to change that. They don't want to get more involved necessarily, unless you're paying them by the hour to lie on their couch, stereotypically. So we need another level, and that level was what at that time was the social worker. So the social worker at that time was a person who was already serving the indigent population, walking the beat, typically in the projects or low-income housing areas and stuff like that, doing welfare checks on the people that were being served, making sure that they were dotting the I's, crossing the T's. But when you looked at them academically, they were actually close to everything in the training that the doctor was going to have to address from a psychiatric standpoint. So instead of being a social worker, academically, we changed it to a clinical training, and they became clinical therapists so that they could diagnose. So we added the DSM to their curriculum and taught them how to recognize symptomology and to give a preliminary diagnosis that would eventually be affirmed or turned over by a prescriber. But that now gave a person an opportunity to lie on the couch in the community.
So this is ultimately what led to mental health therapy.
Correct.
Or not just being a PhD level like a psychologist, but opening up the door for a licensed master of social work to be able to have a mental health focus.
Correct.
Interesting.
And so the master's level became the therapist, and that's who you're actually going to get your community lie on the couch time from. With individual therapy, they're still going to provoke groups, as we've learned as an industry, how effective those are. But then what happened to that social worker? So that social worker now is moved down a level to the bachelor's prepared person academically. So we're still teaching social work, but it's at a bachelor's level. And that bachelor's level is not called a social worker necessarily. They're called a case manager or care coordinator.
There you go.
Yeah. and that's the essence of community health. So that's the description of it now.
Which leads to your modern day structure within a community mental health center. You've
Correct.
got your administrators, you have your prescribing team, your prescribers, you've got your therapists at varying levels, whether it's limited or full license. You've got case managers, you've got peer supports, you've got administrative staff,
Correct.
and the list goes on.
Yeah.
From billers to coders to
Crazy. I didn't think about that actually.
yeah.
Yeah.
It's interesting how it leads to or extrapolates itself or informs our current circumstances
Yeah.
within this community mental health setting.
You know, it's almost like before you work at a CMH or a part of a CMH, you should actually like hear how it started. Otherwise, do you like truly understand why it's there?
No, you don't.
No.
And most people, they don't really care.
Yeah, I mean, I've worked with one for 10 years. I don't know that.
Right.
Never heard anything. I never
Not even
was able to
remotely
put all the
close. Nothing.
pieces together.
I'm just like, oh yeah. go to
Maybe
work.
Michael writes a little history on it.
Yeah.
If you can write code,
Or
you
there
can
should
write a
be
short book.
or like there should be like a video, like even like the state like requires you to like look at to see that to understand what the heck this came from.
We could look and see if there
15
is
minutes
something.
after.
But the history of that's really thrilling to hear. To be
Yeah.
honest with you, it's really cool to see where we've come from over
Yeah.
a short period of time.
Yeah.
1997 to now is not that long.
And I don't personally even like history. I personally hate history, but I think that I hate it. But follow.
It's a strong view.
I know, sorry. I don't hate history, but I don't like remember it. But I'm saying that this is important to know. It's the history of it, obviously, is an aspect of it, but it's also why it's there.
Yeah. It serves a purpose.
Yeah, it serves a
Look
purpose.
at how much
Huge
it's
purpose.
impressing upon both of us. And it's not out of us being ignorant, but
Right.
not being exposed to this information or being able to connect the pieces. It's like you start to understand everybody's role a little bit more,
Yeah, 100%.
which is
Yeah.
cool.
So the CMH, that's how the CMH outpatient mental health clinics came together. And then when the asylums went away, it's where do they stay, right? So they got their care at their
Correct.
CMH. Where do they live?
So where do they live? Now you talk about the adult foster care group homes. And when the adult foster care group homes were implemented, they were, I want to say, as large as 20 beds. So you can have anywhere from a 20 bed down to like a 3-bed home typically. Today, we're best practice says 6 beds is the limit because they don't want to create mini asylums. And that's what they in essence had begun to do with the 20-bed facilities. And then we're full, add 2 more beds temporarily, quote unquote, that kind of stuff. So you just had a mini version of it. And so now there's a law in the books, home and community-based services that came on the books about 2019. And now the state is enforcing it today. You see that window? See that bureaucracy? So that's one of the things with community health.
6 years later.
Full of bureaucracy, right?
Yeah.
But it's to make sure that we don't inadvertently have mini asylums again.
That makes sense. Think
But
about
I shouldn't stereotype here a little bit, but you hear a story about group homes and AFC homes anyways.
Mm-hmm.
Aren't they, isn't it harder? Let's say the state has, just give you numbers here, 10 massive asylums. And okay, we did a bad job, controlling what was going on inside, like the cases, the examples you gave. Wouldn't it be cheaper and more efficient to just say, okay, let's put more management into managing 10 locations and big facilities than saying there's how many group homes are there? 10,000 group homes in the state, and now you're managing 10,000 locations.
Well, I think the logic is, not saying that I agree or disagree, the logic is this. What about the dignity of the person? Like, what other illness do you have where they send you away? Why can't I just manage my illness in my own community in a house as opposed to an institution?
in the home-based setting.
Yeah.
And not to mention, when you hear asylum, there is such a stigma associated with that word.
That sounds terrible.
It would
Right.
absolutely be repurposed as a more permanent mental health care
Sounds like Halloween when you say
Correct.
facility.
Yeah.
But yeah, it always makes me think of Batman, Arkham Asylum.
But,
Yeah.
but
But group homes,
Batman.
you're exactly right.
Yes.
The home part of it, or being able to live in a congenial community-based setting where you still have some control over your environment, what you can do, you still come and go somewhat freely.
That makes sense.
That empowers that individual to be able to focus on their health and their mental health at the same time.
yeah.
They should have you write the mental health code.
Absolutely.
Yeah.
Absolutely. I agree with that.
Yeah, because everybody in a group home is not dangerous, right?
Correct.
Yeah.
And they're not a danger to themselves or others, so they should be able to live freely. If they have an illness,
Absolutely.
we understand that it's just an illness. And let's treat it like that. And let's act like that's what it is instead of acting like, oh my gosh.
Right.
I hope that this episode allowed you to get a little bit of a glimpse into Michael Hunter and all that he's been able to accomplish in 20 very short years. It's incredible, and we're blessed to have him with us today on the pod.